orthodontics in Matsuyama, Japan. He completed his PhD course at Hiroshima University in 2005, and he was an assistant professor at the Department of Orthodontics and Craniofacial Developmental Biology from 2007 to 2012. He was a visiting professor at the Center for Craniofacial Anomalies at University California in 2009 to 2010, and he opened his own orthodontic clinic in Matsuyama in 2012. He was an adjunct lecturer at Nagasaki University and Ehime University. Also, he is a main lecturer of orthodontic basic course using orthodontic anchor screw at the seminar of Gel Medical's Japanese distributor, Proceed Corporation. The title of his lecture today is Planning and Mechanics for Molar Distalization. In this lecture, Dr. Ohtani will introduce the characteristics of upper molar distal movement and mechanics for using surgical guide.
Hi, hello everyone. My name is Junji Ohtani from Japan. I really appreciate Gel Medical Corporation to invite me such a great webinar for Asian countries. And it's very honored to speak with Professor Tae-Woo Kim from Seoul National University and Dr. Okashita from Japan. And this picture was taken in 2019, the Congress of KAO. I was invited to Korea and held a symposium about tats with Dr. Liao from Taiwan and Dr. Lim from Korea. At that time, the chairman of this symposium is Professor Kim, and I was received the certificate from him. I would like to thank you again, Professor Kim. And then another speaker, Dr. Okashita, after my lecture, he is also a great speaker and has a good character. Now, I was looking for pictures with Dr. Okashita for this webinar, but I had no academic photos with him. Only in such a drinking memories were remembered. But I promise that he is a great orthodontist too, so please look forward to next presentation. Okay, so let me introduce myself a little bit. This is my clinic in Japan. My hometown is Matsuyama. Matsuyama is a small island located on the southern part in Japan. So the climate is mild. There are so many oranges can be harvested. But that's all. The Matsuyama is in the country, so we have no idea to show you a special tourist attraction except of oranges. Yeah, and unfortunately, it's true. To stretch a point, there are so many spa in Matsuyama. The most famous one is Dogo Onsen. It's the most oldest spa in Japan, constructed in the 7th century. We always can be enjoyed and relaxed with spa. So after the completing this webinar, I absolutely go to onsen with my family. And this is the gate of my clinic. And this is a consultation room. We can talk about treatment plan with patient and a relaxed situation. And going through the aisle of glass. This is a clinic area. I like outdoor activities, cannot keep working hard inside without sunshine. So the clinic area was also designed feeling like being in nature. Like that. Okay, so let's get back on track. My presentation title is Planning and Makeup for Molar Distalization. So you know the mini screw has firmly established in orthodontic treatment. It is said that one of the biggest epoch making in orthodontic field, just like a multi-bracket system and a direct bonding system. So today I would like to talk about two topics. The first, characteristic of upper molar during distal movement to correct class 2 malocclusion. To realize our desired mechanics, we have to locate mini screw with precision. So I would like to talk that why the surgical guide is necessary. The reason why I focused on molar distalization is that crowding and maxillary protrusion are majority of malocclusion in Asian countries and shown class 2 relationship. So we often have to correct to class 1 relationship by the upper molar distalization. Now, of course, we have to diagnose about the space for upper molar distalization. In the Ceph analysis, there is one effective measurement item from rickets analysis, PTV to upper 6. This measurement item can be predict the space for the eruption of upper second molar. That is to say, we can know that how much space can we move upper molar to distally. So the limitation of distal movement is known by this Ceph measurement. However, the maxillary molar was not always moved to distally because the limitation is morphology of maxillary tuber. The bone housing is gradually reduced as it goes distally. So CBCT view may teach us there is an enough space or not. In this case, we can see a little space in right side, but in the left side, the palatal root already contacted to the boss of palatal bone and the floor of sinus. Under such a situation, it was expected high difficulty of molar distalization. So therefore, we must check by taking CBCT for the judgment the possibility. Okay, so I'd like to show you one case using mini screw located at the buccal alveolar bone. So this case was applied mini screw for recovery because of the lack of patient compliance. It was showed severe crowding with high canine and class 2 molar relationship. We diagnosed 4 premolar extraction to make a class 1 relationship. To distalize upper molar movement, the mini screw is essential. But this patient has refused in use of mini screw because he has a scare too much. So I had no choice but to use conventional appliance with headgear and transpalatal arch at first. The Ceph analysis, there is no big problem and the dental position. So it's okay to correct just crowding. And this is 11 months after extraction. Inconveniently, she never used in headgear and intermaxillary elastics. So after correction of crowding, it is still shows class 2 relationship. Then I had convinced her for the using of mini screw and implanted between upper 5 and 6 buccal alveolar bone in maxilla. So you can see the long hook with 8 mm length soldered with arch wire and retracted from mini screw by using elastic chain. When I diagnosed to use mini screw in buccal side, I always select this mechanics. And finished. we could achieve class 1 relationship with good occlusion in this mechanics. Keeping a good occlusion about 5 years after retention. Before and after. To correct class 2 relationship, the maxillary arch was moved to distally about 2 millimeters. From Ceph analysis, we have investigated about the characteristic of molar movement. In BA group, about 2 millimeter distalization was shown. The between second premolar and first molar or buccal side has minor space was already well known. So when I did a diagnosis, only in case within 3 millimeter distalization was selected, implantation at buccal side. Accordingly, these results are guided by the diagnosis philosophy. And next, we examine the distal tipping of first molar. It was showed bigger angulation compared with PS group. So what is PS group? The PS group means the group which implanted mini screw at the palatal side and retract with lingual arch. So implanted mini screw between second premolar and first molar in palatal side, and the vertical portion of mini screw is 3 to 5 millimeters above the molars. We use lingual arch soldered small hook and retract to parallel with occlusal plane from mini screws. Go back to the result of degree of distal tipping. In PS group showed minor tipping more than BA groups. Of course, the result of amount of distal movement, the PS group showed larger movement compared with BA groups. Because when it needs to molar distalization over 3 millimeters, I decided to implant at the palatal side due to there is a big space between the root of second premolar and first molars. Okay, so how about the differences in vertical movement? As a result, in BA group, tendency of extrusion was shown compared with PS groups. This result means that first molar moved distally with tipping and extrusion in BA groups. On the other hand, in PS group, first molar to distally like a bodily movement. Under such a situation, the last measurement, the changing of facial axis shows increasing in PS groups. So this means that the mandibular counterwards rotation was revealed during molar distalization in PS groups. In summary, when we placed mini screw at buccal side, the limitation of distal movement is under 3 millimeters. And molars are shown extrusion due to tipping to distally. It leads to mandibular clockwise rotation a little bit in this mechanics. On the other side, in PS group, the first molar showed nearly bodily movement with slightly intrusion. It stimulates counterclockwise rotation of mandible. It means that in use of these mechanics may expect to improve convex profile by moving forward of chain position. At this point, I'd like to show the typical case treated by the mechanics of PS groups. A patient is 16 years old female. Her chief complaint is protrusion of both anterior teeth and deficiency of lip closing. It's super convex profile, but we commonly encounter like this case with severe retromandible. Molar relationship shows class 1, but shows too much anterior protrusion. Incisor angle shows 95 degrees, and FMA is about 40 degrees. The SNA and SNB also showed retrographic position. The panel in the initial record, we decided extraction of 4 fast premolars and using PS group mechanics. Furthermore, such a severe high angle case, we often implanted mini screw also in mandible to prevent lower molar extrusion. Because in such a high angle case, it was reported that less bite force indicated. With that as a cause, it sometimes recognizes extrusion of lower molar during upper molar distalization phase due to revealed intrusion of upper molar in PS mechanics. I will show you the dental video. The anterior teeth will go back 9.4 millimeters. And also upper molars need to move distally about 2 millimeters in both sides. This schema shows the objective of molar movement in high angle case. The first, we placed mini screw at palatal side between second premolar and first molar at 3 to 5 millimeters above the molars. And then set the lingual arch with soldered hook and enforce elastic chain from mini screw to soldered hook. Thereby, upper molar moved to distally, already I mentioned. Then, during distalization, lower molar often shows naturally extrusion, especially in high angle case like this. So we also placed mini screw between first and second molar at buccal side and prevent extrusion of lower molars. As a result, the mandible shows counterclockwise rotation and the point B also changed to forward position, like this. After treatment, the both anterior teeth position were well corrected and achieved good occlusion. The panoramic X-ray is a good angulation. And then this figure shows the mandibular counterclockwise rotation was showed during upper molar movement, with keeping vertical position of lower molars. It means no extrusion of lower molars. As a result, the FMA changed from 39.6 to 37.7 degrees. And also NB angle was corrected 4.8 to 3.5 degrees. Her profile was changed dramatically. It's achieved better profile for her, but to realize these mechanics in all cases, we always have to locate mini screw precisely. Okay, so up to this point, I'm talking about molar distal movement. It's about one of horizontal direction, but such a severe open body case is including vertical problem. So we have to consider about vertical control in such a case. So this is a surgery case of skeletal 2. We often to plan we often plan to intrude and distalize of upper molars in expecting of mandibular counterclockwise rotation. The slide showed 4 months and 7 months later, and 11 and 14 months passed. And after surgery, I've excluded molar intrusion and distalization to lighten the difficulty of orthodontic surgery. This is another case showed mandibular functional deviation. The mandible shifted to the left side and also showed the cant of occlusal plane. So we organized 2 main subjects. One is upper right side intrusion, and another subject is only upper right side expansion by minuscules. The before and after, I got a good occlusion. This is very simple, just the slightly intrusion and one side expansion. Also could be improved facial asymmetry without any surgery. As I showed these cases, the orthodontic treatment has a family-wide way to use of skeletal anchorage. Then we can move upper molar position 3-dimensionally. So next, what should we think about? I'm sure that we have to consider about how can I estimate newly position of upper 6 in diagnosis. I include one example. Sometimes young doctor ask me like that, how many millimeter can I move the molar distally, or can I do the molar intrusion over 5 millimeters? But do you think that these questions truly important? Maybe not, I think. The most important thing is I'm planning new upper 6 position. This newly set up position of upper 6 can be achieved with harmony in anatomy and functionally. Namely, the intrusion of upper molar is not just appeared the intrusion of the teeth. We are taking a new occlusal plane. You know, in the Ceph analysis, we can check the occlusal plane angle. So it's easy to measure newly occlusal plane angle after upper molar intrusion we will be planned. In this case, we show the tilt of occlusal plane in each side. When we will take a Ceph, we can put the lead film or cobalt wire on the molar occlusion plane in each side, like that, and take a cephalograms. So we can note in each occlusal plane clearly and to be able to decide the amount of unilateral intrusion in molars easily. Thus, we are able to measure newly occlusal plane angle we planned. That is to say, we can check a newly subjected upper 6 position will be acceptable or not in morphometric analysis. So next, we have to consider the functional analysis. At first, we have to know about the relationship between surgical condylar inclination and the surgical incisor inclination. So generally, the sagittal condylar inclination, SCI, and sagittal canine inclination shows almost same degrees, nearly equal. And sagittal incisor inclination, SII, is 10 degrees greater than SCI. This patient is not still given orthodontic treatment, but he has normal jaw movement and has a good relationship with SCI and SII. So even for the patient has minor crowding not to be given orthodontic treatment, molar disocclusion during jaw movement is secured. After upper molar intrusion, the newly occlusal plane will show steep incline more than initial occlusal plane. In this way or manner, it may reveal occlusal interference in molar area during jaw movement due to the newly occlusal plane angle close to SCI angle. So many articles has reported about the effect of occlusal interference, the bad effect to the TMJ and the muscle, the dental processes, and relapse after orthodontic treatment. Accordingly, it is recommended to define the angle of this occlusion in molars is 8 to 13 degrees. And to establish this angle, we can use these three measurement items: SCI and cusp inclination of upper 6, CI, and the angle of occlusal plane, OP. The angle of this occlusion, AOD, is less than 8 degrees. It may cause occlusal interference, and also larger than 30 degrees. It may cause decline in masticator efficiency. At the beginning, we will measure the SCI. To measure SCI, we can use stomatognatic functional analysis. These data from stomatognatic functional analysis in my patient that we can also transfer to the semi-adjustable articulator easily. So we also check in the setup model before treatment. It's easy to know SCI angle. And next, CI angle, the cusp inclination of upper 6, that always applied to 25 degrees according to Caucasian norm. And last item, the angle of occlusal plane, we also easily get to know from Ceph analysis. So from 3 measurement items, we can calculate the angle of this occlusion. And that is to say, we can check the position of upper 6 we will plan will be acceptable in the functional jaw movement. So it leads to a high requirement for making surgical guide to locate mini screw on demand position. This 3D model was making from STL and DICOM data. We can check the position of mini screw 3-dimensionally. So it's easy to appear my own mechanics corresponding to each cases. So like this surgical guide, it was developed for safety implantation to avoid contact with teeth back in the day. But now, to realize proper mechanics we designed, surgical guide has become an indispensable item for us. This is for lower one, and back bone side, another palatal side. So this video shows implantation to palatal side by using surgical guide. It's very simple and less possibility to contact with loop and mini screws. And biggest advantages of surgical guide is always can be realized on-demand mechanics precisely. Like that. It's very easy. This presentation was supported by these great orthodontics, my colleagues. Thank you so much. And it's been a pleasure being with all of you today. So thank you for your attention. If you enjoy my presentation, please follow my clinic on Instagram and Facebook and please like. Thank you. Thank you for your attention.
Thank you, Dr. Ohtani, for preparing a wonderful lecture. And now, as our first lecture, we will have a 5-minute break time. If you need more time for your questions, please write it in the Q&A.